Welcome to the audio lecture on traumatic brain injury, or TBI. Materials from this lecture correlate to your textbook, chapter 19. So to start out, we're going to take a look at the societal impact of TBI, as well as the pathophysiology. Sometimes people think that brain injury is primarily caused by blunt force trauma, which it can be, but there's other mechanisms underlying traumatic brain injury that we'll want to take a look at. You'll want to be able to interpret, after reviewing this PowerPoint, you're going to want to be able to interpret Glasgow scales of cognitive functioning. When you're interpreting those scales, you'll also need to consider how this may impact what you're doing clinically. There's a link here in the PowerPoint on a video of how to examine the unconscious patient, and we'll go over that in lab. The video isn't all-inclusive necessarily, but I'd like us to think about examination techniques from both our neuro exam, just our exam procedures we've learned up till now, and what can we actually use to examine a patient who's unconscious, maybe in the inpatient setting. We'll also take a look at common complications seen in traumatic brain injury, complications such as contractures, heterotopic ossification, and ways to manage or think about managing these conditions. So it's funny, I think most of us grow up and we don't want to become our parents, and for me, I didn't want to become my PT professors, and yet here I am using the same historical background of Phineas Gage that I'm sure by now every PT student knows, because we all use this when we talk about head injury. So here's the obligatory reference to Mr. Gage. Information from this slide comes from the references listed here at the bottom, CDC information, and a brainline.org article that I think is updated for 2017 or 2018. Big take home here is that TBI is the leading cause of injury-related death and disability in the U.S. So huge societal impact here, 50,000 deaths per year, and it makes up almost a third of all injury-related deaths in the U.S. Falls are the most common cause, followed by car accident, but car accidents are going to be the biggest single cause of traumatic brain injury death. And in that category of brain injury death from car accidents, those in the age range 20 to 24 are at highest risk. Estimated around 2.5 million ER visits per year for brain injury, and direct costs, so that would be the healthcare costs, and indirect costs, which would be possibly lost wages, caregiver burden, everything that goes into taking care of someone with traumatic brain injury. You're looking at upwards of $70 billion per year. The prevalence might be underreported. People may seek care outside of emergency departments, and not all sport-related brain injuries are recognized. Information I found also indicated that military TBI is not included in the CDC data. So according to the reference here on your PowerPoint, what I've seen is we've got about 380,000 cases of traumatic brain injury in the military spanning 2000 to 2017. Blast injury is the most common cause. So military is an interesting case in a lot of conditions that we may see as physical therapists. Improvements in body armor and protection means that some injuries which may have been fatal in the past are now survivable. So a lot of times we'll be thinking of amputations and prosthetics, but we absolutely need to consider TBI here as well. In terms of societal impact, it's estimated we have a little bit over 5 million disabled in the community or in society from traumatic brain injury that are living in the United States, and up to 40% are not working 1 year after traumatic brain injury. As we go through TBI and we think about areas of the brain that can be affected, this will make sense. So beyond the general impairments such as tone or strength loss or sensation problems, there's going to be a lot of problems with executive functioning, so that frontal lobe or prefrontal lobe. How are we carrying out our daily activities? Have we remembered certain things? So these higher level processing can be affected in TBI, and this is what we're using when we actually work. So up to 40% not working 1 year after traumatic brain injury. I was taught in PT school that the rate of divorce is fairly high after TBI, but I went back and looked at the literature, and at least what I could find, doesn't seem to necessarily be the case. So to me, it would make sense that the rate of divorce would be high after TBI. The person's personality has changed. Maybe it's not the same person that you had married, but it was nice to find out that maybe this is not the case, that the rates of divorce are not necessarily high. Table 19.1 from your textbook gives one way of classifying traumatic brain injury. This is not a table you'd have to memorize by any stretch, but I think it gives you a little bit of guidance on how you might classify. Mild TBI, you could also consider that concussion. We'll cover concussion later in the course, and I think there's been a shift in labeling concussion as something benign or mild, that whole, oh, just got his bell rung, get back in the game, to realizing that it's actually a form of a mild brain injury. We've discussed in prior coursework the Glasgow Coma Scale. We're going to hit it again today in this lecture. So if you look at this chart, though, you can see that the GCS is also used to kind of label mild, moderate, and severe. So as I'm looking at this table, for me, clinically, that's the part of the table I'd probably want to remember. Is mild TBI is 13 to 15. Of note, 15 is the highest score on the GCS. So they're saying, hey, you could have a GCS score of 15, and we're still going to categorize you as a mild TBI because maybe you had a little bit of a loss of consciousness or an alteration in consciousness. So keep that in mind. But GCS 13 to 15, mild TBI. GCS 9 to 12 would be moderate, and severe would be anything under 9. So I think, as we're thinking about using that Glasgow Coma Scale, knowing the ranges would be helpful for you. As we think about the societal impact a little bit more, here we go with the ICF model again, and it's just vital to keep this in mind. So we're treating body structure and functions. They've probably got some tone problems, maybe some spasticity, some altered strength that's affecting their ability to walk, etc. But let's say they progress through and their strength is good, they're walking, they still may not be able to fully engage in their prior participation roles. As mentioned before, they can have executive issues. Maybe they can no longer do math. Maybe there's a bit of a frontal release where emotionally they're not acting appropriate. Maybe their memory is impaired. So keep in mind, as PTs, we are treating in those body structure and functions and activity, but brain injury can be devastating on participation. And this is where also, if we think about younger people or possibly military, they've survived these devastating injuries. They've recovered physically, but now what are we doing to get them back into society, to give them an active role in society? That's really, I think, a big pressing question with traumatic brain injury. So let's take a look at the pathophysiology of brain damage. Diffuse axonal injury, this would be, if you picture the axon, I may have a picture of it on the next slide. If not, Google it. But what we're saying here is that the injury is not necessarily isolated to one area. It's diffuse, and it's sheared, basically, the axon. So almost like a shearing force. This is going to be a little different, obviously, than CVA, where if you think back to your vascular syndromes, we could, at times, localize the lesion a little bit better, say, well, it was this vascular supply, so we're going to get this relatively straightforward constellation of signs and symptoms. Diffuse axonal injury, not necessarily going to happen. So in this one, it's going to be the force of the angular acceleration. So you're thinking, sports, car accidents, quick start or quick stop. That's what's going on here. But I think clinically, what we want to keep in mind is that what we're going to see may not be very predictable. So we have to have our eyes open. We have to kind of be on our game with brain injury because we may not be able to predict as much as we were with CVA what we're going to find. Focal injury would be something like a contusion, a bruise, a laceration, or if you had a hematoma. So let's say you get hit in the head with a baseball and you get a hematoma. The deficits or the area of injury is going to be in that focal area. A contra coup injury, I think I have a picture of this coming up. That would be the initial injury. Let's say you're accelerating forward and you get hit in the front of the head, but then as you decelerate and your neck goes into extension, you're going to get that contra coup injury of the brain hitting the back of the skull. So you kind of have a two-pronged injury at that point. An open so you can have closed or open injury. Open injury would be skull fracture, so it makes sense that closed, the skull is intact, open, skull fracture. So that's primary brain damage. So that's the initial, whether you want to call it impact, insult, however you want to describe it. So diffuse axonal injury, focal injury from blunt or direct trauma, the coup contra coup from kind of acceleration, deceleration. You can have secondary brain damage that occurs. So hypoxia, ischemic injuries, things that come up. Let's say that now you've had the brain injury, and I think to me the hypoxia and the swelling edema are kind of correlated in a way. I don't know that I'm smart enough to distinguish between those two, but you're basically getting these secondary effects from the brain injury. I do want to point out the concept here, ICP, that's intracranial pressure. We'll talk at length about that later in the presentation. This is the leading cause of death after brain injury if someone survived to the hospital. Rising intracranial pressure is something that if you're working with patients acutely, you're going to want to keep an eye on. Electrolyte imbalance and mass release of damaging neurotransmitters. My area is not so much in the concussion realm, but I've worked with people who have a lot of experience there. And there's, I think, mounting evidence on the importance of this electrolyte imbalance and changes in neurotransmitters. So we should get to some of that on Concussion Week as well. Concussion would be a loss of consciousness, either temporary or permanent, results from blow to the head or an injury. You can still see changes in heart rate, respiratory rate, and blood pressure. Here on this slide, I think this is taken from your book. Concussion, obviously you don't need the loss of consciousness. It's possible to be diagnosed with a concussion without a loss of consciousness. This slide is not exhaustive. It's not all inclusive. The point here is to consider different ways that the brain itself could be injured. So primary brain damage, secondary brain damage, or then via concussion. A concussion probably falls along the lines of this primary brain damage, but a lot of people, I think, arbitrarily separate it out. So here's a slide as promised of the diffuse axonal injury. So on the left we see normal axon, we see the shearing of the axon in the middle, and then we see the death of the brain cell, the neuronal death. The axon's been sheared. We're in the central nervous system where, as far as we know, this is not going to be reparable, so it won't be repaired. And then, so our options for kind of recovery would be creating possibly new synapses, new pathways, or learning ways to compensate for this injury. On the right, we've got the MRI, and so we see those areas that are obviously pointing with the arrows of where the diffuse axonal injury has occurred. Again, this isn't a CVA vascular syndrome. The territory that's involved can be variable, so as you're working with patients who have sustained traumatic brain injuries, you're going to want to be on your game and be, I guess, open and flexible to possibly doing a more thorough exam or an exam that's a little less guided because you're looking for possibly a wider range of deficits. Videos included, but here's an example of a coup contra coup, also a picture. So we've got the initial coup, that's the front of the head, and then as the head snaps back, you're going to get the contra coup, the brain hitting the back of the skull. So now that we've discussed the kind of the pathophysiology of brain injury, let's say we're actually working with someone in the clinic, and it doesn't matter whether it's acutely in the inpatient rehab. This is going to be a team approach, so there's going to be a lot of teamwork. This is where you can't be kind of an island as a PT. You're going to be interacting with a lot of people. Probably most importantly is patient and family. Physician's going to be heavily involved, speech and OT, rehab nurse, case manager, social worker, maybe a neuropsychologist, may have respiratory therapy, may have recreational therapy, etc., etc., etc. Point about the patient and family that I want to make up, I try and weave in a lot of patient first or patient centered approaches. I've talked before about the importance of interacting with the patient in a primary sense rather than just the family. So if you go in and you're seeing someone acutely and they're comatose, they're not moving, obviously they're not going to give you a history. You'll need to talk to the family. But what I would recommend as you go in is you can still introduce yourself to the patient, then turn and talk to the family. You still proceed as though the patient can hear you. We never know to what extent someone can or may be able to process information, and we're fortunate enough we'll have a guest patient coming this week, and he and his family will talk about it. I'll also mention, I think I mentioned in last week's lecture on CVA, the book where the magazine editor had sustained a pretty massive stroke and had locked-in syndrome, but he was completely with it. He could understand everything that was going on around him. So maybe that happens in a small percentage of cases that these patients are understanding us, but I think it's important enough, and I think it's easy enough for us to just still interact with our patients, tell them what we're going to do. So maybe you go in the room, patient's unconscious, you say, "Hello, Mr. Smith, my name's Mike Powers, I'll be the therapist working with you today." You turn to the family member, you say, I'm going to be the therapist. Can you tell me a little bit about your son, daughter? You ask them to introduce themselves as well. Keep them in the loop of what you're doing. But then as you're going through your exam, you might say, "Okay, Mr. Smith, I'm rolling you onto your left side now." And just talking to them, they're still a person even if they're not responding. So obviously it's a little bit of a soapbox for me, but I think what you'll find is you've done right by the patient in that case. You'll have a better alliance, a therapeutic alliance with the family. And if the patient does progress out, you may hear them say, "Yeah, I heard you talking to me. That was really helpful." So let's try and get that ingrained early on, interacting with your patient directly as much as you can. I want to put this picture in there because as a new clinician, and I'll be honest, even as an experienced clinician, this is a scary picture. Scary for us, but think about it, it's probably much more scary for the patient that's there. So we'll talk about some of the lines you may encounter in acute traumatic brain injury, some of the interventions you might be kind of coordinating to help in these initial phases, and then how we may want to move on from there. Biggest thing I think as you're starting out, and again we're saying that we're working with someone acutely in traumatic brain injury, check with the nurse. The nurse in these cases, he or she is going to be your best friend. So if someone is heavily involved, traumatic brain injury, the nurse to patient ratio is probably going to be pretty low. The nurse should have a pretty good handle on what's going on with that patient. There's other times where you can probably on the inpatient ward check the chart, just say, "Okay, nurse so-and-so, I'm going in," and boom, done. Pretty easy. Here, it's probably worth the 5 or 10 minutes or whatever amount of time to really chat with the nurse, kind of get on their good side and work as a team. You may even be saying, "You know what, I'd like to see, depending on how it goes, if you think it's safe for me to get them out of bed, would you be able to come in and help?" So again, a team approach is really going to be critical. Be aware of any precautions. So we'll talk about intracranial pressure, if the person's on oxygen, if they're on a ventilator, if they have various lines that you need to be aware of. So really check yourself before you go in. Make sure you have a good picture of what's going on. You'll know these precautions by reviewing the medical record. So again, not to kind of be biased in a way or be dismissive of other diagnoses, but there's some cases where you're working with someone, they're overall fairly healthy. Maybe they've had a total joint replacement, they're doing well. It's possible you can go a little quicker, maybe you're not quite as thorough. But here you really need to be thorough and make sure you're very aware of what's going on. Here we go, beating this dead horse. We've covered arousal in so many lectures up till now. So here we go again. And a lot of times in TBI, you're not going to have the patient that's alert. So you're going to want to look and see which level of arousal they're at. Glasgow Coma Scale, we've covered a little bit before. You may or may not be the one administering this. Most likely you're not. Most likely this is documented in the chart that patient came in with a GCS of 8, and there's other further documentation about it. So You can use this, though, as you're working with someone with a brain injury, especially if you're new. Maybe you have a copy of this to your clipboard, or you think, okay, what should I be looking for? And you could, throughout doing your regular exam, probably give them a GCS score. Now, it's not necessarily predictive of function down the road. Remember, we talked about this is predictive of initial mortality, but you still could look at some progression by looking at how they're moving through the GCS. And here we go. So this was, again, I've put this in the prior lecture. Initial score and GCS of 3 has a mortality anywhere between 65 to 99%. So that is pretty bad if someone comes in with an initial GCS of 3. Does appear to be that predictor of the initial mortality, but not subsequent function. So similar to, remember in CVA, hemorrhagic stroke has a higher mortality risk, but it has no difference in function compared to ischemic stroke later on. So here, GCS does predict initial mortality, but it has not been found to be predictive of subsequent function. To me, it would make intuitive sense that if someone had a higher GCS score, they're probably going to do well functionally later on. But I think what this is pointing out is that, let's say you've got 3 or 4 patients who've come in with an initial GCS of 3, they all survive. It's probably impossible to predict where they're going to end up functionally. Couple links here so you can get familiar with some lines, and I think on the presentation here we'll also show you a little bit more about the ICP monitors. But as a student, I was not well versed necessarily in the different types of feeding tubes, where they went, what their precautions were, where should I put my gait belt. So take a minute to go through and look at these feeding tubes. So when someone says, oh, that's a J tube, that's an NG tube, etc., you'll kind of know. Fortunately, these lines are based off anatomical structures, not someone's name for the most part. So NG, nasogastric, J tube, jejunal tube. You'll be able to piece together the anatomy, but I think it's still helpful to know where these lines are coming from. Patients that have sustained traumatic brain injury may have undergone craniotomy or craniectomy. Craniotomy will be the surgical removal of part of the skull. This procedure is used a lot of times to remove brain tumors, but in cases of TBI, main reason it's going to be used is to help with treatment of swelling. So craniotomy, they'll remove the skull and they'll replace that area. Craniectomy, they've removed a part of the skull, and for now at least they're not replacing it, so the patient will actually have an area that's open. Helmets may be used after these procedures, especially if the patient's under seizure precautions. If you work in a pediatric setting or a setting working with patients with developmental disabilities, you may see patients with helmets. Those are usually those softer helmets. And at first, when I saw these clinically, I was not sure what was going on. So I just bring this up to try and clear up confusion. You might have, these helmets are designed to protect someone's head in case they should have a seizure and they end up going down. This is important because there is an increased risk of seizure after traumatic brain injury. Gave you the definition of seizure here, but I think most of us are kind of familiar with what a seizure is. There's a lot of events that can trigger seizures. It's not funny per se, but it is that stress is kind of a trigger for everything. The human body and the brain don't like stress in general, so stress is kind of up there near the top. Could be missed medications, flickering lights, so that's why if you play video games, you'll notice those warnings. People with photosensitivity or seizures, check with your doctor, because there have been people playing certain games that have had seizure activity. Medications you may see will be Dilantin and phenobarbital. So be aware of these because these medications can have also effects on overall either arousal level, drowsiness, those types of things. Little reference for you. This is from Vanderbilt University. Just a little table on seizure precautions. Biggest thing here is if you're working with someone who does have a seizure, you'll want to get them comfortable and get them into that sideline position. As healthcare providers, obviously we're not physicians, but you may run into occasions where you might be a first responder. And in most situations, if possible, if the person's breathing and does not need CPR, that side lying or that recovery position, if you get someone in that position, you're doing well. Okay, so let's put a pin in this slide. This one's important. Intracranial pressure. As previously mentioned, this is the main cause of death after traumatic brain injury. And what happens, there's an uncontrolled rise in ICP, usually within the first 48 hours. Normal pressure is going to be under 20 millimeters of mercury. And if you think about it, what's going on here, the danger here should be readily apparent. The skull is this rigid and closed structure. If our pressure starts going up, there's nowhere for this pressure to go. So again, this may be a reason why maybe a patient has a craniotomy, craniectomy, give a chance to relieve some of that pressure. There may also be some monitors that are used that not only monitor the pressure, but may help in diverting some of the cerebrospinal fluid or some of the fluid that's contributing to this increased pressure. Found some debate in the literature regarding effectiveness of measuring ICP. So just put a couple additional readings here. One reference was in favor, one was not in favor, and one mentioned the risk of iatrogenic injury. So if you're not familiar with that term, iatrogenic means kind of hospital caused or treatment caused. So anytime you hear someone say, oh, this was an iatrogenic infection, means it's an infection someone picked up from being in the hospital. So non-healthcare providers often think the hospital is the safest place to be, but you and I know that as soon as you can get out of the hospital, you want to. So regarding ICP measuring, some evidence in favor, some not, and there could be iatrogenic injuries. Reason I think that some references are not in favor is that a good clinical exam and constant monitoring of vital signs can kind of alert you if something's going on. I don't know where, this is my area of expertise, I don't know where I fall on this. I would tend to think if a hospital was a brain injury center and could monitor mine or my loved one's pressure, I'd probably want it, but I understand that it may not change the outcome. So if you have some time, take a look at these articles. As far as I'm aware, there's not a definitive yay or nay on measuring these pressures. I bring this up, though, because if you're working with a brain injury population and you're in the acute care setting, if someone is having their pressure monitored, you're keeping a close eye on that. If they're not having their pressure monitored, you are watching their vitals like a hawk. So here's some ways to measure ICP. Couple different types. Intraventricular catheter is going to be the most accurate, and I believe this one is also capable of extracting some cerebrospinal fluid. As I look at the picture and look at the diagram, looks like that's an open-ended insertion. So someone, if you find that I'm wrong later, please correct me, but I do believe that that one is capable of removing some cerebrospinal fluid. Subdural screw is the quickest, but you can see obviously where that's located, or here it says subarachnoid. That's not going to be able to remove any fluid, but it would be the quickest. The epidural sensor is less invasive, but a drawback here is we cannot use it to remove cerebrospinal fluid. This gets a little confusing about the Cushing reflex, so I'll do my best to explain it in a fairly clear way. As far as I can tell, the Cushing reflex is kind of separate from Cushing's triad, but they're interrelated. So semantics, I'm not sure how important it is to not get these mixed up, because you'll hear Cushing's, and is it the reflex, is it the triad? So for our purposes, and as best I can tell, the Cushing reflex is the response to the increased intracranial pressure, and the reflex itself is going to produce the sign of Cushing's triad. What is Cushing's triad, you asked? I'm so glad you asked. Let's talk about this. Easiest way to remember this, Cushing's triad is a response that's opposite of usual for shock. So I think if you take a second, imagine someone goes into shock, you know that you're going to breathe a little bit faster, your heart rate goes up, and your blood pressure in general goes up. So Cushing's triad occurs as intracranial pressure rises and the response is opposite of usual for shock. So typically a decrease in respirations. They may be those Shane Stokes respirations. Got a YouTube video here. Those Shane Stokes, you got kind of a change in respiratory pattern. You may get a few quick breaths, then slowing down, and then a period of time where there's almost no breath being taken. Doesn't have to be the case in Cushing's triad, but it can be. So biggest thing here, remember, for our purposes, a decrease in respirations. Bradycardia, so instead of an increase in heart rate, a decrease in heart rate. And then a widening in pulse pressure. So increasing difference between systolic and diastolic. So systolic blood pressure is going up. And I do apologize, I may have mentioned previously in shock that blood pressure is going up. It's actually going down, which is why the heart rate goes up. So just want to correct that real quick. So let's go back. Cushing's triad, we're going to get fewer respirations, lower respiratory rate, lower heart rate, and systolic blood pressure goes up. This is considered a medical emergency. This is a sign of impending brainstem herniation or impending brainstem death, basically. Here in the little picture, little asterisk says it should not be confused with Cushing's syndrome, disease resulting from elevated levels of blood cortisol. So here we've got multiple Cushing's all over the place with these operational definitions. That's just confusing us. So Cushing's triad is the sign of increasing intracranial pressure. Our response is opposite of that of what's usual for shock. So if you're working with a patient and their ICP is being monitored, they'll be able to see that the pressure is going up. If, though, you're working with a patient, ICP is not being monitored, and you notice respiratory rate is going down or there's a change in the respiration, you notice that, you've had someone, let's say, supine, you've gotten them now sitting edge of bed, their heart rate was 85 before treatment, now it's 50. Should not be happening. They're moving around. Their heart rate should be stable or going up. You've now got lowering heart rate. You get that patient laying back down, check vitals, and probably you get the nurse. Same thing with blood pressure. You get a blood pressure, and then as they're working, you notice that their systolic is going up. Their diastolic is not going up. That would be a concern. So you look for all, obviously it's a triad, so hopefully you're learning throughout this course. A lot of things don't exist in isolation. You're looking at combination of things. So you're working with the patient, you get those respiratory changes, bradycardia, and pulse pressures. You are moving fast to alert the nurse about what's going on. So next, let's talk about key examination features. I brought up the key pages from your text here and the box from your text. I think starting out as we're working with someone, let's again imagine that we're seeing someone acutely, inpatient side, this posture, positioning, arousal, attention, and cognition, and integumentary, that might be the bulk of what we're doing initially, depending on where this person's at. The other thing, it's listed at the bottom, should probably be higher up. Ventilation is probably something we're going to be checking. If they're on oxygen or on a ventilator, we may be checking their O2 saturation as well. But here in traumatic brain injury, especially acutely, you may not be able to do a full exam. You may be splitting it up into stages. You may be doing only as much as either the patient can tolerate or as much as is important to at least start the plan of care. As mentioned previously, it might take multiple sessions to complete your evaluation. And as you're working with the patient, keep monitoring the vital signs. Hopefully by talking about Cushing's triad, I've impressed that upon you that we need to always be monitoring the vital signs. Someone's starting out and they're able to participate to some extent. If you're able to get them up sitting edge of bed, that's great. If you're able to get some transfer started, the more you can get them up safely and move them, the quicker you can do that, the better. And then remember, previously we talked in class that early initiation of gait seems to be kind of a wake-up call for the nervous system. So I'm not saying early on you're just picking the patient up and dragging them up and down the hallway, But when they're able to progress to that point, even if it's not kind of classically good looking gait or it looks very abnormal, the sooner you can get them up safely and walking, the better. So what about the unconscious patient? A big consideration for treatment is informed consent. And I looked in the literature regarding this and couldn't find anything very specific, so I think this is clinical judgment. I would tend to think you're working in the hospital, your patient's unconscious, the doctor has ordered that you go in and start working with the patient, probably to help with positioning, look at range of motion needs, get them started to hopefully prevent some bad initial outcomes. In those cases, especially if family's there, I think you can get informed consent via the family. You're not doing anything that's putting them at a huge risk. I've never myself personally had an issue working with the unconscious patient under referral from the physician. I will say though, keep in mind that you are thinking about this is your license on the line, even under a physician's order. You are operating as a licensed practitioner. So if you have concerns, either speak to the physician, maybe speak to a more senior colleague if you're worried about going in to see the unconscious patient. Great YouTube video. It's not all-inclusive. So as we work in lab later on this week, we're going to be simulating an exam of the unconscious patient. Don't assume that everything you saw in the video are the only things or that it's everything. Think about what's in your toolkit or what you can apply. It's about a 12-minute video. I would encourage you to go ahead and watch this and get an idea of how you might do it the same or different. It's probably pretty rare that you would have to examine the unconscious patient, but there's few things that'll make you feel as incompetent as going in to work with a patient who's unconscious and not knowing what the heck to do. So I think this video is a great reference. It gets your mind thinking that, oh yeah, I can still check some things, and it'll give you that starting point. Because you may, whether it's in clinical practice or possibly on one of your clinical rotations, be working with someone that's either unconscious or not very alert and oriented, and having some tools or some skills that you can use is going to save you a lot of discomfort. We've covered this quite a bit, so we're talking now about posture. So you go in the room, how is the patient presenting? So remember, decorticate is from problems with the corticospinal tracts. Upper extremities are kind of in that classical flex position. Lower extremities are extended. Now that you know a little bit more from the course, we've kind of assumed that a lot of times in CVA, that upper extremity is typically in that flex position, like we see the arms in decorticate posturing. So decorticate, corticospinal tracts, CVA, those all kind of go together. Decerebrate posture is arms extended. Again, I remember this. Decerebrate has the E in it, D-E-C-E, decerebrate. I remember that. Oh, E for extension. That's basically how I keep it together. And the decerebrate posture is more from the result of brainstem problems, so that's going to have a worse prognosis. Pupillary response in doll's eyes. This feeds into your examination of the unconscious patient. I put this on here because it's not something that you might normally run across, but it is some powerful tool you can put into your toolkit. So the video, go ahead and watch that first. First you'll see as they shine the pen light, there's no response. So what we know there, we didn't get to see fully the other eye, but we can assume there's no response. So we know we don't have a direct or a consensual pupillary response. So problems with cranial nerves 2 and 3 right off the bat. The doll's eye response is in the unconscious patient. If you turn the head side to side, the eyes will initially, they won't move necessarily, but then they'll kind of catch up. And if you've had one of those, I don't know, I kind of think they're a little creepy, but those dolls where the eyes do move, that's what they're talking about. In a conscious patient, there will be no doll's eyes response. That reflex is inhibited. But in an unconscious patient, they should have this doll's eye response. In the video, you'll see that as they move the patient's head, the eye does not move. And I think just kind of gut reaction, it looks weird. You could know not much of anything and look at that and say that eye should be moving and it's not. So I think intuitively you know that that's not a good response. Obviously, to do this, the cervical spine needs to be cleared, so this isn't a test you do with someone who's being ruled out for a cervical injury, but if the neck's been cleared, you can look for this doll's eye response to see whether there's been some brainstem involvement. It's talked about on the YouTube video of the unconscious patient, but I wanted to put a little bit more about it here. Page 867 of your text talks about a couple other scales that can be used for arousal, attention, and cognition. For our purposes, we're going to focus on the Rancho's levels of cognitive functioning. You might see that abbreviated as LOCF. This is what, when I worked in the inpatient rehab setting, this is what was used for communicating about patients with brain injury. It's been a number of years since I worked in that setting, so I'm unsure if that's still the gold standard. But it seems I see it a lot in the literature, so I think it is still being used pretty regularly. So here's the levels, and your book, I think, splits it up into kind of subcategories. So levels 1 to 3 is going to have a certain kind of treatment thrust or way of looking at what's going on. Levels 4 to 6, a little bit different than levels 7 to 8. Some references stop at 8. Other references go till 10, and I think the 9 and 10 are included, and it's great that they are included as more being aware of limitations in participation, because you can get to 8 and you think that everything's fine, but this still may not be a person functioning independently in society, so these 9s and 10s are good to keep in mind because they indicate that there are still issues that this person may be dealing with. Box 19.4 from your text gives you a great synopsis of what things you may be looking for if someone's in Rancho's stages 1 to 3. So here's where it might be that acute setting. You're starting out with someone, they're probably not interacting much with you. What you're really trying to avoid, you don't want them to get contractures. You don't want them to get skin breakdown. You want to start getting them moving around to the amount that they can, trying to encourage them being more physical functioning, getting a better level of alertness. So as mentioned, you want to maintain range of motion, prevent contracture development. I do want to take a moment here to talk about contractures because I think, according to some discussions I've had with students, there's some confusion about what a contracture is. So let's take that example we've used during discussion of patients with CVA where that arm is kind of flexed at the elbow and curled in towards the body. If someone has spasticity or tone, being postured in a certain way, that is not a contracture. That's being positioned in a synergy pattern, or that's tone or spasticity, however we want to call it. A contracture is a legitimate change in the connective tissue where moving out of that position is either very, very difficult or basically impossible, whether that's because of changes in the cross bridges, changes in the collagen. That would be a contracture. So someone acute TBI, acute CVA, you see them postured, let's say elbows bent. That is not a contracture. That is a problem because of their tone or their spasticity. Now, if we do not maintain that passive motion, if we don't move them out of that position, it can become a contracture. But just being positioned there is not a contracture. And I want to be very clear on that point because I don't want you going in the clinic and erroneously labeling someone as having a contracture either in your note or in discussion to other healthcare providers, because that is incorrect. And tone spasticity is managed differently than contractures are. So you want to be very careful about labeling something as a contracture. Regarding contractures, serial casting is mentioned as a treatment. Evidence I saw regarding contractures did mention that Botox injections and serial casting had some good evidence for treatment of contractures at the ankle. So serial casting would be you put someone at their current end range, you provide that low load, prolonged stretch. Then after a certain time period, cast is removed, you recast them. Hopefully they've picked up some motion. You recast them in a new position to further stretch them. Skin integrity is critical, and this can apply traumatic brain injury, CVA, spinal cord injury. Anyone whose mobility is compromised, you need to think about how you're going to maintain skin integrity. For the person with brain injury, if they're in a Rancho's level 1 to 3, they may not be alert, they're not awake enough to move, so we need to think about those bony prominences, those heels, if they're thin, those areas near the scapula or the coccyx area, the sacrum. Are they on a turning schedule? Are they on a pressure relieving bed? And again, that team approach, how are you going to work with others to coordinate so we don't get a skin breakdown? Respiratory status is going to be critical. Most of the time now, if this is involved, it's going to be respiratory therapy working with the patient. But keep in mind that your physical interventions, moving the patient, getting them out of that supine position will help also with the airway. Now think about stimulation for arousal. Now we're not going to go in there with glow sticks and a disco ball and house music, but we want to start slowly adding some stimulation to kind of increase the arousal. As mentioned before, posturing can put patient at risk of contracture. So if they have significant tone, can't move out of it, and they're stuck in a position, they're at risk of contractures. This stat kind of blew my mind that over 80% of patients with traumatic brain injury are going to have a contracture, most of them at the ankle. So they're going to end up with a plantar flexion contracture. Contracture is named based on the muscle group or tendon that is contracted or tight. So Achilles gets shortened, which effectively puts you in a plantar flex position. Keep in mind the effects that a plantar flexion contracture would have on mobility, not just on gait. Think about how it may affect transfer. So we've discussed in lab how you need to position that ankle correctly to perform a sit-to-stand transfer. Try standing up if you can't get your ankle to at least neutral dorsiflexion or a little bit further. If your ankles are in plantar flexion, your weight is going, your center mass is being pushed backwards. You are not able to stand up. You're being thrown backwards. So you may be working with someone acutely with traumatic brain injury, wondering, well, this is just, this positioning, how much does it matter? If we can prevent that ankle from getting contracted, you've set them up for success down the road. And then the reference here on serial casting with Botox, as I previously alluded to. Heterotopic ossification, easy for me to say, heterotopic ossification is a potential side effect of many neurologic conditions. Brain injury common, may also see it in spinal cord injury. Text mentions it happens in about 20% of cases with traumatic brain injury. What this condition is bone formation outside normal skeletal locations. Elbow and hips seem to be most common. I linked a article here with some background information on HO. What you're gonna, I guess if you're working with someone, the way you would start to wonder whether HO is happening is you start noticing a loss of range of motion. This is where it may be a hard end feel. Think back to surface anatomy, musculoskeletal. Your end feels normally at the elbow shouldn't have a hard end feel. If you're moving into flexion, you may get a hard end feel here. You're also going to maybe get warmth and swelling. So want to know this condition so you don't erroneously think it's an infection or you're not sure what's going on. But heterotopic ossification, I've seen a few of these along the way. The problem is they're challenging to treat. There's debatable evidence whether aggressive range of motion actually makes it worse. I think they can be surgically removed, but the risk of recurrence is pretty high. So these are unfortunate and not very fun. Okay, so let's review real quick. So Rancho's levels 1 to 3, someone's in those early stages of kind of waking up. They're not participating a whole lot. So you're trying to get them to participate more in a safe way. You're really watching their positioning because you want to minimize risk of contractures and you want to maintain skin integrity. As we move into levels 4 to 6, the person's starting to interact with you a little bit more. Now they're going to be confused, they may be agitated, so you're going to have to be careful about how you go about with your treatments. Biggest thing you can do here is providing structure and consistency. Here you're not going to want to overstimulate someone. You want, and think about motor control, motor learning. We talked about different environments. Closed, reduced stimulus environment, daily schedules and memory logs. In this level of treatment, you may consider still doing the treatment in the patient's room. As they start to progress, you may be able to bring them down to the therapy gym, but you don't need a lot of extraneous stimulation. So structure is key, consistency is key. Task-specific training. We see that motor control, motor learning in here. Your patient used to play basketball. See if there's a way to encourage him or her to dribble a basketball or mimic shooting a basketball or get a Nerf basketball. You have them sitting maybe edge of bed. They're working on their sitting balance and they're trying to get a chest pass to you. So it's not anything textbook per se. You're tapping into what in their history has a good motor pattern. What do they like to do? What can I use to my advantage? Provide frequent orientation to time, place, that should be your name, and the task. So you're just going to keep reorienting them. You're not going to argue with them. You're just going to tell them, oh, today's Tuesday, you're in Leavenworth, today's Tuesday, my name is Mike. You're just, again, not arguing, you're just kind of reorienting them. I think that the patient we have coming in, family may talk about that a little bit and how that can be a little frustrating, but done correctly, it's very helpful. Emphasize safety and behavioral management. So you can get, in this stage, patients, again, can become agitated, and we'll talk about safety concerns. They may also be inappropriate, so how you manage this can be challenging. They may say things that are socially or sexually inappropriate, and you'll have to be comfortable with how you want to handle redirecting them without getting mad or agitated yourself. As we progress to stages 7 and 8, and we stop at 8 because usually by the stage 9 or 10, they'll be out of that inpatient or possibly even outpatient setting. You may not be working with patients at that point. So 7 and 8, you're going to allow for increasing independence. You are moving from closed to open environments. So this is great. It's continuing with that motor control, motor learning. You remember open and closed environments. Well, this applies to brain injury as well. So we're moving from closed to open environments. They're in the gym. There's a lot of distractions. Can they stay focused on the task? Can they perform dual tasking? Can they walk and talk? Can they sit down while they're carrying a tray? Those types of things. Start thinking about community reentry. I've got a list of some community resources towards the end of the PowerPoint that can help. We're not just getting these people back home. Oh, you can transfer, great. You can walk, great. These a lot of times are younger people or people that have a lot of years ahead of them. How are we going to get them back in the community? So you may need to advocate for your patient. Yes, there's social workers. Yes, there's neuropsychologists. But many times patients are telling us as PTs more than they're telling others, or we may know more about community resources. So be an advocate for your patient. Get in there and tell them, if possible, what's available out there. Don't just be satisfied with that they can walk 150 feet in the sterile gym environment. Think about, well, can they walk out in the community? Can they go to the bus stop and get on a bus? Have you been using a memory journal throughout? Are they aware of compensatory strategies maybe for their memory or executive functioning? And that kind of ties in with that last line here, promote independence in functional tasks. This might be depending on your facility, you do an outing with someone. Some facilities let you go out in the community. Maybe it's the recreational therapist that does this, maybe OT, maybe PT, but you kind of want to see how they do. Can they go to the store and buy a drink or buy some food? Can they count change? So things that we typically don't think of as PTs are going to be critical in brain injury. Table 19.3, the concept of restoration or recovery versus compensation. I think you're going to be having this discussion in your head or this debate on most conditions, and it's one I don't know that anyone 100% has the right answer to. If at all possible, I think you shoot for recovery, you shoot for restoration. But when there's safety concerns or discharge date is drawing near or patient is getting very frustrated, you move towards compensation. So here's some questions you might be able to ask yourself regarding that question of restoration versus compensation. Touch briefly on safety before, and we're going to talk a little bit more about that. Environment, we've also talked about. Think about the role the environment plays in avoiding overstimulation or adding layers of complexity as the patient progresses. Memory cues, memory journals, writing things down helps. And we'll talk about community resources, or I'll show you the list of ones that I've gathered. And I've only been in the area for a short amount of time. I've listed the community resources I'm aware of. Feel free to add ones to the presentation, and or if you find ones that I'm not aware of, please share those with me. So safety, big issue. I've only seen or worked with a few patients in the inpatient rehab setting with brain injury. We had teams when I worked there. I was on the spinal cord injury team, so this was not my main area of focus. I have worked with, though, and talked to therapists that have worked on as members of the brain injury team, and safety is a big consideration. Things that you normally wouldn't be brought front and center. So ties, lanyards, these can be items that can be used to choke. And I'm not saying this to scare everyone, but these are, especially in that agitated stage, your own safety is a pretty big consideration. So what you're wearing, there may be some changes there, and use of a buddy system or having people around during treatment is pretty critical. Procedures for combativeness, because you don't want to be obviously confronting a patient or getting in a physical altercation, but there need to be understood procedures for handling that. So if you're working in brain injury area, especially in early stages, your facility should have policies and procedures for how to handle combativeness. And in any diagnosis, you want to minimize the use of restraints. So sometimes they're necessary so patients not injuring themselves, but to the biggest extent possible, we're going to want to minimize restraints. Environment, low complexity to high complexity. So low light, low clutter, progressing to brighter, more cluttered. So early stages, you're probably treating the patient in their own room. It's a familiar environment. It's a very closed environment. Later on, you're bringing them down to the gym, taking them out in the community. I bring up the issue of smell. I think it applies to brain injury. I had this experience working in spinal cord injury. I had a case manager that came down while I was working with a patient who'd sustained a recent spinal cord injury. I had him on the tilt table trying to get him used to being more upright. And she came by and she had on some pretty strong smelling perfume. And I looked over to my patient and he was kind of changing colors and he got very nauseous. The smell was overpowering for him. So be aware that smell can be a noxious stimulus. You may smell great drenched in Axe body spray, but your patients may not appreciate it. So my personal approach is I'll just use deodorant, nothing else on top of that. If you decide that you do use some fragrances, go pretty light. You don't want to overwhelm your patients. Some memory cues you can employ. Photos of team members I've heard is very helpful. Memory journal is great because what you're hoping to do, maybe at the starting point, either you or the family member is keeping the memory journal, but maybe this is a compensation strategy that the patient can learn to use to kind of manage their memory deficit, so they know, oh, my memory's not so good, I need to write this down. And if we're honest, we all have issues with memory where we need to write certain things down. So it's not saying that the person has no hope. It's just saying, well, your memory's a little bit more impaired, and the more you write things down, that's an effective coping strategy to be more functional. Sleep is critical. It's critical for all of us. We all know we do worse with little sleep, but the recovering brain needs a lot of sleep, so helping with sleep hygiene is critical. Try and avoid becoming emotionally overloaded. That goes for both the patient, but that goes for you as well. So a lot of times emotions can be a little bit contagious. So I think the challenge working with brain injury is that you're going to have to put yourself in a calm place yourself, kind of expect the unexpected, and be able to let some of these things that you'll see wash over you a little bit. So you got to also take care of yourself. I think I've harped on this quite a bit, but community resources are critical. Think about getting these patients back in the community. As they start walking, transferring, again, I'm making the assumption that they've progressed and they've done better, but usually people do recover functionally and physically very well from brain injury. That hard part is figuring out which key is going to unlock getting them back into the community. And so plugging them in with resources is going to be vital. So as we're working with our patients, please, please, please don't neglect consideration of participation. A couple community resources I wanted to put out there. I want to call attention to Minds Matter. I've not worked specifically with them. I've met some of their employees. They're an organization that provides treatment for patients with brain injuries living in the community. And so they are seeing patients months and years possibly after injury. And I do think that we have a clinical rotation set up with them. So that would be an interesting experience. It's very different from typical therapy, but it's providing that kind of participation level therapy, which I think is tremendous. So that's been brain injury in a bit of a nutshell. Looking forward, what we're going to be doing is looking at an exam of an unconscious patient, figuring out how we'd approach brain injury in the acute stages, and then we'll be going over some case studies as well. So any questions, please bring those with you to class, and we'll see you in class.